For joining us for part one of Surgery Department's How to Survive and Thrive webinar series, Scheduling and Block Management Simplified. During this first session, we will focus on how block scheduling can increase surgeon, staff, and patient satisfaction and OR utilization, increase effectiveness of resource utilization, increase inpatient bed utilization, smooth hospital discharges, decrease patient holds in ED, ICU, or PACU, and reduce staff overtime and turnover. In order to keep background noise to a minimum, everyone will be muted. We encourage your questions at any time throughout the demonstration. Just type your question in the chat box and we will answer any questions at the end of the session. Our presenter today will be Stephanie Randa. Stephanie is the Vice President of Analytical Solutions at YourCare Universe. She received her MBA and MHA from the University of St. Francis. She is also certified as a Lean Six Sigma Black Belt. A registered nurse, Stephanie has membership in AORN, ANA, and TNA. She is certified by the Certified Nursing Operation Room Program. Stephanie, take it from here.
Thank you, Lauren. Well, thanks everybody for joining us today. Again, we are going to be talking about block scheduling and really how to optimize your operating room. I know one of the key foundations in operating room management is really around blocks and how you could manage those. So I know there's been many a time that I have either had a phone call from a irate surgeon or from a CEO to make sure that we're able to get a physician on the surgery schedule. So hopefully some of the recommendations that you'll be able to come away with are things that you could do relatively quickly and kind of get started. So again, the objectives for today's webinar is really to identify strategies in order to optimize scheduling. We want you to understand the role in the executive committee and the OR committee. This is something that we'll be talking about, and it's very key to the success of using block scheduling. And we want to identify 3 tactics that you could use to optimize your daily OR schedule. So why is the perioperative area important? Well, 68% of hospitals' revenue can come from the operating room. 60% of a total hospital's margin is from the operating room. Each wasted minute costs between $60 and $100. Adding a 1-hour case in each OR every day can increase profits up to $500,000. You also want to improve your surgeon, staff, and patient satisfaction, which will result in your increase in market share. So here's a polling question, and we'll ask you to go ahead and answer these, and we'll see these at the end of our talk. The poll is open. Do you use data to drive decisions in your operating room? We want to increase that patient satisfaction as well as OR utilization. Again, if it's difficult for a surgeon to get onto the surgery schedule, or it's difficult for their patients to get on the surgery schedule, then those patients become dissatisfied because a lot of times they want to have surgeries done as quick as possible. You want to be a good steward of your resources. There's about 4 departments that are affected by an OR schedule. It could be registration, your preoperative area, your OR, of course, and then your PACU. And if those are not well used, it takes a lot of people in order to cover one patient. So you want to make sure that those resources that are very expensive are used wisely. You really want to increase your inpatient bed utilization, and so that is something that you want to work closely with your manager, your counterpart that's part of the nursing unit on the floor, because you want to maintain enough bed coverage. You want her or him to have the necessary staffing to cover that, and you want to also make sure that the turnover of those rooms on the nursing unit are managed just as well and as tightly as your operating rooms are, because again, it will back things up. You want to smooth out those hospital discharges. Again, if the beds are not turned over, if patients are still waiting, those will result in backups. You could decrease your patient hold in your ED, your intensive care units, or your recovery areas. So that's all because of your block scheduling. And you will decrease your staff overtime and turnover as well. Staff get really frustrated, your OR staff will get really frustrated if they're waiting for cases to start or blocks are going late into the evening or on weekends. So you want to make sure that you're managing those well. And then there's the reality for the surgeons in that really the OR block allocation must be reviewed and really needs to be adjusted quarterly by an executive committee, and we'll get to that in just a second here. But you want to look at the utilization, and the metric that you're measuring is the total block minutes available divided by the total surgery minutes, including your setup and cleanup time. And I know I've gotten a lot of pushback from some OR managers because it's like, well, why are you including that? It makes my numbers look bad. But if you don't do that, then you don't have a full utilization picture of your operating room because it looks like you're less busy than you really are. And you want to establish a threshold for losing the block time. If it drops below a particular percentage, is it 50%, is it 60%, what is that time? And those surgeons have to be aware of that and adhere to. And then establish the process that is really all done in your executive committee. And so the best practices that I have found is really to reallocate blocks based on the productivity and a goal of at least 65%. And what you're going to do is you will look at your current data and that number you will be driving that. So if your rate is typically 50% of your blocks are being used, then you may have to drop it down lower. But that's typically the percentage that I like to see it at is 65%. And you want to have your blocks released by specialty. And what I mean by that is neurosurgery, orthopedics, all those will have different release times than, let's say, general surgery or cardiac surgery or some of those other areas. And you want to use your historical scheduling data in order to make these decisions. You have to be very grounded in the data and feel very confident in your data if you're really making some of these tough calls with this. You want to be able to release blocks, and that again it comes from your OR committee and the policies around that for add-on cases. In additional elective surgeries and new surgeons, that's when you're going to start filling up those times because you want to use your add-on release times for that. And then again, your committee is going to enforce and review block times and utilization. And so the policy really requires administrative support. This is really important if you go this route using an executive committee, because you don't want to set up a policy and then only to be called again by somebody in administration to be able to say, I just got an irate phone call from a surgeon and he can't get his surgery cases on. So you want to be able to balance that and make sure that they understand what they are agreeing to. And I would recommend starting with a blank slate. A lot of times, if you've inherited an old block policy, there's a lot of history that maybe goes with that. There was maybe a surgeon at one time that was using a block, now he's not using a block. And so a lot of those policies get outdated very easy, and nobody really wants to tackle writing a new policy. But I would really recommend starting fresh. You want to establish that policy around what your goals are. So if you are trying to drive new business, you want to be able to structure your block policy that allows for that. So additional add-on rooms, additional add-on, if you have add-on cases, open time. So you want to be able to make sure that those things are added to that policy that's going to help support that new business. You want to, again, have that scheduling policy reviewed and adhered to. A lot of times I would put a reminder on my calendar from the last time I reviewed it, so I would review it again the following year if I had to, if it was 6 months, again, depending on your turnover, your physicians, or as things change. So you want to be able to review that and just not let it slide, because it's really easy to do. And again, you want to use that executive committee to review and support those tough decisions for what times that you're going to use and your utilization. So I've been promising, I keep talking about this OR executive committee. So here's the structure that I've used in the past. It's been very helpful to me. And if you want to think about this as a four-legged chair, and you have to have really the support for somebody from your C-suite, whoever your surgery department reports to, your CEO or your CNO. You want to make sure that you have a surgeon leader. This is usually somebody that maybe is maybe one of your top complainers. Those are always a good person to kind of channel. And your OR director, your OR manager, whatever title that you might be using, and then an anesthesia leader. Many times you just see the kind of the left-hand side, or I'm sorry, the right-hand side of this diagram, and it's the OR director and anesthesia that are trying to make these tough decisions. And what typically happens is the surgeons feel left out. They feel like they don't get a say in this, and that these decisions are made in a vacuum. So I really don't recommend it. I would really try to recruit a surgeon that would help you look at data and make some decisions based on that data. So here's another polling question. So do you have a perioperative governance committee to support block allocation and decision making? And you may call it an executive committee, an OR committee, but they help make those kind of decisions. Good. It looks like we've gotten a lot of folks that do have a committee. That's great. Get back to that. Okay. So some of the things that you could use this committee for, if you're not already using it, I like to establish a charter. It puts things in writing. But to enforce any type of policies and procedures, not just your block utilization, but you could do this for any of your quality projects or any other policies that are as part of the operating room that you might want and feel needs to be reviewed by a higher level in order to get surgeon and anesthesia buy-in, as well as your nursing staff. I really think that it goes a long way when you tell your nursing staff that a policy has been reviewed by a surgeon, and whoever your surgeon leader is and your anesthesia leader, so they feel like they're not kind of out there by themselves trying to enforce a policy. They also would look at dashboards. Having a dashboard to ensure the goals and improvements are being met. So you want to be able to track things, whether it's your turnover times, first case on time starts. So you want to have those kind of metrics available to you, and so all your leadership team is able to look at those. You want to allocate, of course, that surgical block to those folks that are using it, and you want to look at your surgical volumes. You want to keep that in mind. So the question is, should you block? So that I always like to use it kind of an 80-20 rule. 80% of the rooms, of the available rooms, are blocked, and 20% are not blocked. And you want to use those for open or urgent emergent rooms. Those, again, and I'll give you several reasons why you want to do it that way. You really want to make sure that these blocks are with at least 8 hours long, because many times you have a tendency to say, well, I'll give this surgeon a half a day block. Somebody will use it for the half of the morning and it'll be open again at 1 o'clock in the afternoon. It's really difficult then to get somebody else to want to work during that same day, during that afternoon, or you get that one surgeon is in the morning, they may go later than planned, and then the surgeon in the afternoon is bumped, and now you have to find another room to put them so they're not delayed. So you want to make sure that your gaps, is that really the 8-hour blocks really help minimize those gaps and reduce overtime. You want to really look at the surgical volume since the surgeons know they need to maintain a certain utilization to keep that block time. So again, you want to kind of use this as some things as a carrot to let the surgeons know that you are looking at that. If you use the kind of the carrot of having a specialty team available to them, if they're able to keep their blocks at a certain utilization, that would be something that you might want to consider as well. And because I think the message that you're trying to send the surgeon is that you want to make them efficient, and you want them to be productive, and you want to make use of their time as well. So I think then they tend to appreciate that. So this is just a suggested block release time guidelines. And so I know that some of you are probably coming from some hospitals that are larger or smaller, and again, this is an overall guideline. If you have your cardiac services, a one-day release. So basically, if somebody comes in with chest pain, there's not a lot of time that you want to take, and so you don't want to release that time too far out because you do have somebody that needs surgery. The rule of thumb that I try to also use is really is to look at the type of patients that for these different specialty services, and let the patient really kind of determine that. So if you look at general surgery, 3 to 7 days, but you're also probably going to want give them some open time because again, people don't necessarily just walk into a general surgeon's office just to kind of, they have a problem, they're usually in pain, and they want something done about it. So if the end result is that they need surgery, they usually want it relatively soon. They've been NPO, they don't want to wait any longer. GYN, you have a little more leeway. Typically, people like to plan their times when they're having GYN surgery. They know that they have to plan for coverage, things like that. Head and neck, again, is a little shorter span. Neurosurgery, again, a little on the short span because, again, patients are in pain. Ophthalmology, you usually have a little wider window of time. Orthopedics, same there. There's a lot of planning and preparation that goes with that. Plastic or cosmetic surgery, 7 days is sufficient in urology as well. So you might want to use some of your current data to kind of look at that and just as it kind of test that out to look at how far out a particular surgeon or service is scheduling and kind of keep track of it that way. And that's how I kind of keep track of it myself. So you really want to look kind of at your current state as you're starting down this road to make changes to your policy and to your block allocation. What's your current utilization rates? As far as your surgeons, how are they using their time? What's the overall block utilization? And then your total OR utilization. Because many times there might be some concurrent rooms running that you want to look at. Many times your anesthesia providers are subsidized by the number of ORs, and so if you say that you have 10 operating rooms and they are contracted to cover 10 operating rooms, and you really are only using maybe 6 of those operating rooms, you might want to keep track of that because you've paid for 10. So you want to be very mindful of those numbers and how they're calculated. Are your cases exceeding your block? Are you always going over, or is the time running short? Do you have a lot of excessive overtime? And so those are the kind of things that you look for. The best advice I could give is as far as looking at these blocks, you want to demand match your staffing according to your blocks. If you reduce your blocks, then you reduce the number of hours that you have staff coverage. If you extend your blocks, then you have to have the staff to extend into those hours. Are there scheduling gaps in that elective schedule? If you have big gaps of time, that's going to be problematic for you. Are you scheduling your procedure times accurately? Again, I would use your current data to determine what is the average time that those particular procedures are running. If you see or that they are, many surgeons never realize how much the total time that they use. And you might want to ask them that. Why is their time, why are they requesting a particular shorter time than they typically have done? Many times it's their staff their office staff that might be doing this, and again, you're just trying to make sure that you have the coverage that they need. Are your first cases starting on time? If they're not, this is going to push and delay the rest of your cases, so that again is going to affect your overall utilization. And what is your delay rate? Are there cases that are again running later, or are there delays? What is the day of surgery cancellation rate? Typically, I like to see this at a 1% rate or lower. I know that sounds really low, but your patients really need to be called prior to the day of surgery and to confirm their readiness. Is your preoperative evaluations complete prior to the day of surgery? Are all those things taken care of? And all those things will affect your cancellation rates. So let's have another polling question. Do you use your data to allocate blocks, to allocate the block allocation? We're opening that up. The polls are open, and go ahead and let's see how that. Let's see. Yes, so 59% said yes, and 42% said no. All right, so just some things that you could do to optimize your utilization is to really look and define your start times and to really spell that out in the scheduling policy. I can't tell you, I think I bet I had at least 90% of the hospitals that I visit, when I ask the staff, when I ask anesthesia, and when I ask surgeons what the start times are, and when I ask the OR manager, I get 4 different times. So that's usually, again, very dependent. So make sure that you spell it out in the scheduling policy. Make sure your staff know it and understand it, what it exactly means. What does wheels in mean? If that's what you're going to use. I've had, some surgeons where they want the start time to be the incision time. I don't recommend that. That's nothing that anybody could really control. So again, you're going to, it's hard to manage to something that you can't control. So again, that's kind of usually what I would tell surgeons. And determine who's reviewing the schedule and making adjustments to those length of cases. Who is going to be that person that looks at this and goes, okay, we can move some cases, we can pack another case in, or let's make a phone call and make sure that this length of this case is going to be right. Who's going to make the decisions to manage the add-on cases? If it's anesthesia, you're going to, more than likely, if the case could wait, they will put it on for the next day because they don't like to be, they like to work during their work hours. They don't like to necessarily be on call and stay to finish those cases. So who is it that's objective that could do that? I usually refer it to whoever who was the board runner because they know what staff you have available, etc. You want to be able to gather that historical data on the case length for surgeons to use in planning and forecasting, because again, you want to make this as predictable as possible. There's no need to walk into an operating room in the morning and go, oh geez, I hope we have enough staff to cover these cases today. And I all know, we have call-outs and things like that, but you know that, kind of what you've left in the day, and, if it's changing a lot in the middle of the night, then, maybe there's some other things that you could do to get some more predictability around that. Use your information systems. I know some of you have electronic documentation systems. There's usually reports and data that is in those, so that's something that you really want to be able to use. If you don't have an IT system, or you're looking to, maybe you're not feeling a little comfortable by it just yet, ask your staff. The staff know how long it takes a surgeon to do a case, so that they're always a good resource if nothing else. And again, look at that data on case length and review that with your OR committee. Second rooms. This is always a great question. People always want to know, should we flip cases into a second room? Should we stagger starts? How should we manage a second room? So really, there's some things that you kind of have to ask yourself. How many cases are required to give a second room? How many cases does a physician have to have before you say, okay, yes, let's give him a second room? Looking at the time of the case and things like that, that's really important. So if you look at the type of case, such as cardiac or total joints with long turnovers and long closure times, that may be a good indication of, that might be a good way to determine to give somebody a second room. But if it doesn't take long to turn over a particular case, it's probably not worth giving them a second room. I know it's kind of a psychological thing for physicians. They feel like they can get the cases done quicker if you give them a second room, but that may not necessarily be the case. Do you have the required resources? Do you have the additional instruments or additional equipment? Or you have the additional staff? If you only provide partial staffing in order to get a case started, this probably isn't going to help you a lot. Again, I know it's very psychological when we deal with surgeons, and they feel like it's very important to get that second room. But if you really don't have enough staff to cover it, you're going to be doing a lot of changing out and delays and starting and stopping. So I don't necessarily recommend it. And again, if you have to turn over instruments, or if you're moving equipment from one room to another, it's probably going to slow you down. And then, is it going to really decrease the cases running over? And then you have to know when to say no. Again, if you stretch your staff too far, if you stretch all your resources too far, then that's going to be, sorry here, guys. That's going to be problematic because then the staff start getting upset. Why did we give them the second room? Anesthesia gets upset. Why did you give them the second room? So you really need to know when to say no. And again, your executive committee should really establish those policies. I wouldn't recommend giving second rooms and leaving that to chance. Really, you have to really plan for it. And then, what's the surgeon's criteria? What does the surgeon have to do in order to make this happen? A lot of times they have to meet the efficiency goals of first case on time starts. If they are not on time, then why are we giving them a second room? If their paperwork isn't complete prior to the day of the surgery, and those are the things that you can use to help incentivize a surgeon as far as your second rooms. How do you manage the second room? I think the one thing is that sometimes the surgeons, again, they take this for granted. This is a very expensive resource. So the surgeon really needs to see and mark all the patients before they enter the room. If they're hopping back and forth to do this, that's really not helping anybody. They're wasting a lot of time, walking up and down the hall. So if we can get all those patients marked before they enter the OR, that's going to be more helpful. Then, and if the surgeons really need to assist with difficult positioning, if they don't have a physician's assistant or someone that can help, they can delegate this to, then it's going to be difficult to get a second room started. So again, they need to make sure that they approve that, because you don't want a surgeon to come in and say, well, this isn't positioned right, and tear everything down. The surgeons really need to make sure that all their documentation on these cases are completed when that patient is ready to go. They need to make sure that the discharge criteria is on the chart and ready, and orders are in the PACU. Because again, if they have to, if they have to run to the PACU in order to discharge a patient, that's going to be problematic. It's going to delay getting your cases started. You want to allow anesthesia to look at inducing maybe the second patient, and again, this is really something that you have to look at your policies to make sure that somebody is able to cover that case in the event of a delay, but you really need to kind of look at what's the timing that you're going to induce that second patient. And, you know, I always had a role called the board runner, and I really advocate for this, is somebody that really has the big picture in mind as far as the operating room, and they're really the ones that are managing that second room. They're the ones that, because a lot of times you may get a call out from the surgeon that is requesting a second room. It's like, oh, you can put my patient on. Well, you know, it usually is beneficial if you walk back just to make sure that all things are moving as planned, and there's not going to be any delays. So they're the ones that's really kind of managing the time. When do you bring the second patient in the room? Those kind of things. And again, I think any of the cases that are really are uncertain, or a lot of possibles, so it could be an exploratory lab, possible this, possible that. You probably don't want to put those on as your first case. So cases that are longer in length, they need to be scheduled appropriately. But if you're not certain about them, don't make those your first scheduled case of the day. That would be the last case, and then have a more predictable case in the front end. Because again, you don't want your elective case or your elective patients perhaps maybe to be bumped, or the case is running longer. Do the smaller cases first, and really, if you don't place another case after those possibles, then that's something that you might want to consider. This allows you to really improve the overall management of that elective cases and patient satisfaction. Again, you don't want to have to go back to a patient and say, well, something's occurred, and so we have a delay on your case. Emergent, urgent, and add-on cases. So this is something that could really play havoc with your day. And again, it's really important to have data collection is really the key to planning this. Typically, Mondays are your add-on days, and so but your add-on days, and so that's why again it's important to have that data collection. A lot of times, the midweek is the high volume time. This was an article that was in the Wall Street Journal, and said that a lot of times physicians want to schedule in the middle of the week because it makes it a lot easier for their schedule on the weekends and things like that. And so this really causes a problem with the overall OR schedule and how things are running as far as a smooth running hospital, because it also plays havoc with patients being discharged, etc. You might want to leave one room open for the unplanned or urgent cases for surgeons with limited block time. Many times if a physician doesn't have enough volume, there might be somebody that maybe works at another hospital, they're a splitter, but you don't want to turn them away. Maybe their patients want to come to your hospital. And so you want to make sure that you're leaving some open time for those particular physicians. This needs to be on a first come, first served basis. You also want to make sure that you don't have people kind of not being as honest as they could be as far as putting some of those cases on if they don't have block time. But you want to make sure that your open rooms are have a release time that are available until about noon on the day before surgery. Otherwise, they're reassigned at the discretion of the OR, in order to streamline the surgery schedule. And usually, it's the person that's your board runner that's usually doing those kind of things. So a lot of times, I hear from the OR managers is that that they then have add-on cases on weekends or nights, and so they're doing cases that maybe aren't necessarily quite as urgent as need be, but their staff are there late into the evening, or they're there throughout the weekend. And what do you do about that? Well, the best thing that I could recommend, and this came from the Trauma Injury Journal, is really to put your add-on cases in some type of leveling system. And this is what they recommend is level 1 through 4. So level 1 or emergent is life, limb, or sight-threatening conditions requiring immediate surgery within 1 hour of taking them to the OR. So you want to make sure that when a surgeon says, I need to get my case on now, that it's fitting within that criteria. Same with level 2. It's not life-threatening, but the condition may lead to complications if the surgery is not performed within 4 hours. Level 3, again, not life-threatening, but it may lead to severe complications if it's not performed within 12 hours. And then level 4 is really, again, not life-threatening, but it may be for an inpatient that can't be discharged until the surgical procedure is performed. So you want to make sure that they fit in these categories. And if you have surgeons that are maybe you feel like they're abusing the add-on privilege, then are they fitting into these criteria? If they're not, then use this as a way to get, again, your executive committee involved to be really looking at these type of patients that they're bringing in, and maybe there's something else that you could do. So here's some, where you would start as far as if you want to be able to look at your new policy for block scheduling. Establish the start times. What are those start times? Remember, nobody seems to, everybody has a different ideas what the start time could be. Establish really what your utilization rates are going to be. If the block utilization is at 60%, is that going to be acceptable? Again, these are just recommendations when it's not acceptable, and then room for growth. Set the requirements for the block request. How soon do you have to put in a block request? What's that time frame? What's going to be the number of hours in a block? Again, we talked about the ideal is at least to have 8. Establish what that acceptable length of time for notification for a surgeon if they're going to release the block is. We all know that they take time off, they have vacations, they have conferences. If they don't release the block, is there some kind of ramification that occurs? Because again, you've kind of put a fence around their time, and if they're not releasing that somebody else could use, that becomes a problem. And again, what are those release times for those specialties by surgeon or specialties, and looking at what they're typically doing. Establish rules for outside of an assigned block. So usually, again, if somebody is asking for a second room, you look to schedule inside the block first, and if it's not in an open time, you want to create that open time for provide that available for your new surgeons. Communication, and I can't stress this enough. Really, when you just get your block finalized, begin, the next thing you need to do is to outline your communication plan. And I would use letters, emails, calls, one-on-one meetings. Make sure that you're communicating with individual surgeons. If you have to provide bad news that you're reducing a surgeon's block, that requires a one-on-one meeting, and hopefully somebody from your C-suite will sit with you while you're having that discussion. Surgeons like to see data, and if you could provide that data as far as why you're making that decision. You want to make sure that you're educating your schedulers. These are the folks that are really your enforcers when it comes time to look at your policies. So they're the ones that have to kind of, again, communicate to those office managers and things if they can't get a physician on. So again, you want to communicate with your physicians, the office managers, and your schedulers. You want to communicate with your OR staff and anesthesia, and of course your administrative team. You don't want anybody to be surprised that when you've made the decision that this is your new scheduling policy is going to go into effect. Monitoring your block, you really have to have a reliable method to monitor your block. Who is going to actually pull this data for you? Who is going to be the one looking at it? It's not always your OR manager. Maybe it is your scheduler. I found that they're usually very good as far as knowing what reports to run. Make sure that it's accurate. Again, you want to make sure that your numbers are correct. Assign this analysis again on a monthly basis and set the deadlines for when the reports are. This really has to be done again on a regular basis, and discuss it at your OR executive meeting. So some steps to follow: assign somebody consistently to be responsible for the patient flow, whether you call them the air traffic controller or the board runner, but somebody that's going to keep things running. You really want to get that OR executive committee established and to set up to review the data. You want to spread out those elective cases and smooth the schedule as much as you can. You want to match the staffing to the surgical volume, and you want to, as well as the skill mix. So again, demand matching. You have 10-hour blocks, you need 10-hour staffing. Establish clear expectation and goals for your block scheduling. What is it that you want to accomplish by establishing blocks? And use a policy to set those expected surgeons and utilization rates. Move any of those unpredictable cases to a separate room or to follow a predictable case. Develop methods for monitoring that's really consistent and objective. You have to be fair because, again, if you start going, kind of breaking your own rules, and again, we all get kind of pushed, but just make sure that you are able to allocate appropriately. Review the blocks monthly and follow up quarterly with communications to surgeons and administration. I typically send out letters, so again, your physicians knew how they were doing and whether they're acceptable, whether they need improvement, those kind of things. And then implement the changes gradually. But open, and again, be fair. Some mistakes to avoid. Don't overblock. If you are already at 80% of your prime time is already blocked, you really need to consider opening additional ORs or extending the blocks because that's very tight. You want to release time should really be established with the goal to find another case for that time period. That's what your release times are for. It's not because you don't want to do the cases, it's to look for another case. And I would also just kind of going back and looking at your 80%, if you're at 80% and you don't have additional operating rooms to open up, and maybe before you extend the time, you want to look at your release times. Again, that may be an easy fix as well. To look for the resources for those specialty blocks, make sure that before you're adding blocks, additional time, make sure you have additional equipment and the skilled staff because that's going to really stress your system. Rely on those schedulers as the voice of your department and really customer service. If they are stressed because they can't get surgeons on or the office staff is frustrated, then they need to make sure that you are open to that kind of input and really maybe put some other things that you could do to help in place. If you put rules in place, really support your schedulers. So that, again, is really just some words of wisdom. AORN recommends some advantages for really designating one OR for unscheduled cases. They feel that if you reduce, you could really reduce running after hours by about 15%, and you could really increase some by 10% some of your regular business hours. The increase in the ability to accommodate 10% growth in surgical volume over 2 years is what they've identified. And satisfied surgeons, because they're routinely not working late or add-on cases. And again, you increase that surgeon productivity by almost 5%. Some additional tips for better scheduling is really look at your nomenclature. You really want to standardize that. So is it hip arthroplasty? Is it right total hip? What is it? What is it that you call it? Develop a standardized scheduling form or fax, or send it electronically with required information. Provide a dual monitor screen for your schedulers. This sounds very simple, but if information is coming to them electronically or it's faxed, they're able to pull it up and they're able to easily enter in information. This is a small thing to do, but it's a big perk for them. You really want to communicate with that physician's office. I always like to have, you bring in donuts. It goes a long way by communicating in person to letting them know any kind of changes that are out there. Getting their feedback, getting any input that they have, again, is very important. And you want to review your policies and procedures with them to make sure that they're aware of it. So, in summary, be fair and consistent in reinforcing rules. Be sure you have administrative support. Establish with schedulers a clear understanding of their roles and what their rules are that they are to follow. And be sure you have surgeon and anesthesia leaders there to help you with any of those hard decisions. So thank you for joining us for our first series. We have a Part 2 series that will be coming up March 8th, and that's using data to improve safety, quality, efficiency, and utilization. And Part 3 will be simple steps to improve patient satisfaction in your perioperative area, which is Tuesday, March 22nd. You can go to our website, and you can also see that we have partnered with AORN for the Perioperative Efficiency Toolkit. So that's something that you can launch from our site as well. And some of the tips are there. This will be available by electronically as well.
Thank you, Stephanie. That was really interesting. We've had a couple of questions come in. The first one is, if DOS cancellation rate is of 1% only for scheduled cases, or does it include add-on cases? I think this is a question from the early part of the presentation.
Right. So I would have that as your elective cases, but if you are putting an add-on case on as a first case of the day and that patient is not prepared, then, again, I would put some criteria in place. If it's an add-on because it's urgent or emergent, those shouldn't affect your numbers. But you really want to make sure that those patients that are added on are also prepared. So that might be a question that you have your schedulers ask: is this patient ready for surgery? Have they had all their workup and things?
And a follow-up question is, where can I get access to that kind of data, and how do I use it to create the block?
Well, a lot of this is within perioperative systems, your electronic systems. MedHost has a perioperative electronic system we call PIMS, and it allows for data, it allows for dashboards and be able to run these kind of reports to help you manage your operating room.
Great. And another one. Blocking seems like a great idea, but our team is already spread very thin. Do you have any suggestions on how we can get a project like this started?
Well, yes, it does take time, and it's nothing that you want to rush into. Here at Your Care Universe, we do provide consulting for any additional help that may be needed. I know many times it's not that you don't have the ability as an OR manager or OR director to do these kind of things, but sometimes it takes recommendations from an objective outsider, and that goes perhaps a little bit farther. So.
Great. And then I can answer this last question. Will the slides be available after the presentation? And the answer is yes. Within the next couple of days, we'll send out an email that has both the recording and a PDF of the slides that were shown today. It seems like we don't have any more questions. Thank you for your time today, and look forward to following up later this week. Thank you for being with us.